Good morning. My name is Nico de Vries. I'm an otolaryngologist from Amsterdam, and at World Sleep, I was asked to give a keynote lecture on sleep surgery, and in that lecture, we'll be discussing 4 aspects of sleep surgery: drug-induced sleep endoscopy, surgery itself, positional therapy, and upper airway stimulation. And in this talk, I will focus on upper airway stimulation alone. And the first presentation that I will be giving is on the so-called Inspire Upper Airway Stimulation system. Now, it's important to realize that there are many systems in various phases of development. Most experienced by far is with Inspire. There are now some 16,000 patients in the world who have had this implant, and the second best in terms of development is the Nixoa Genio system. But there are others, as the Livanova system. Cardiologists are working on stimulation of the phrenic nerve for central apnea. There's even a group working on stimulation of the ansa cervicalis. Now, the pivotal paper for upper airway stimulation was the paper that we published in New England Journal of Medicine already 8 years ago, a large multi-center international RCT on upper airway stimulation. The whole principle is stimulation of the hypoglossal nerve, which is a motor nerve, which is responsible for tongue movement. It is only a motor nerve, so people often ask, is it painful? But no, because it is not a sensor nerve. And the nerve has different branches, and branches that you want to stimulate, of course, are the protruding the branches that bring the tongue forward. And important is also that there is a phenomenon called coupling, which means that when you stimulate the tongue, then the palate often opens as well. We see this later. Now, here we see the main branch of the nerve, and we now know that there are retracting branches that you want to exclude and protruding branches which bring the tongue forward. And this is where you want your stimulation to be. The Inspire system has 3 components. There is the IPG, the implantable pulse generator, the pacemaker, with the sensor in between the ribs and another sensor around the hypoglossal nerve. And the patient puts on his system when she goes asleep. The sensor detects inspiration, and then the signal through the IPD is sent to the hypoglossal nerve, which brings the tongue forward. And the principle is, of course, very simple. When you stimulate the muscles that open the airway, you open the airway. And this animation shows it in more detail. So this is how the signal goes. It's only during inspiration that the stimulation is happening. During expiration, the system is off, so the tongue can relax. And on this animation, you see this forward movement of the tongue. During surgery, we start with putting some electrodes in the lateral side of the tongue and in the floor of mouth to be sure that when you performing the implant, that you put the cuff around the right nerve. So red is retraction, it's not good, and blue is protruding in the floor of mouth in the genioglossus muscle. And this is how you start your surgery. Here you see identification of the hypoglossal nerve, and by turning it around a little bit, you often will find a few small retracting branches behind the protruding branches, which you need to exclude. So you see how we use the nerve stimulator. So by using it, there are several ways to be sure. The sound is different, the movement is different, the signal on the screen is different. So, and you can even look into the movement of the tongue in the mouth. So it is a kind of idiot-proof surgery. It would be very strange to put the nerve around, the cuff around the nerve when you use this NIM. This is the cuff that is placed around the protruding branches. And the first few times that people perform the surgery, they usually find a little bit uncomfortable. How do you know that you don't damage the nerve? But with all the experience that we now have had all over the world, as far as I know, never ever has happened some permanent nerve damage. So the nerve is kind of friendly to the surgeon. It is not that vulnerable. And the small branch that you see here is C1, which we want to include because that is responsible for forward movement of the hyoid bone, which gives some extra opening of the airway. Then there's a tunneling device that we need to use to bring the wire, the lead, under the skin from one incision in the neck up to the second incision on the thorax. And you can use this tunneling device to either place the wire under the platysm, which is cosmetically the best, and sometimes you can be above the platysm, which might be a little bit safer, but visible. So ideally, we place the wire under the platysm. Then you need to create a pocket in between the ribs in an intercostal space between the internal and external intercostal muscles. Again, in the beginning, this also feels a bit uncomfortable because how do you know that you're not entering the pleural cavity? But that also has never happened. As long as you stay in the same direction as the ribs go, you will be good. This is the sensor, which is placed in this pocket, and you need to be careful not to damage it. But there are places on this sensor which are safe to use, and then you will not damage the sensor. During the surgery, when you put the sensor into place, we continuously check if the signals that we are recording are good. So here you see the inspiration signals, and with the after placement of the sensor, you are not happy with the signal, you of course reposition it until you are good. Now, this is the older sensor where we put it in between the fourth and fifth rib. We now do it under the IPG, which is even easier and gives an even better signal than you are seeing here. This is the implant. Important when you put it in the pocket is to take care that the wires are under it, so that when you need to replace the sensor at a later stage because of depletion, that will take about 10 years, that you don't damage the wire when you open the wound. Presently, the patients go home the same day. We do this in daycare. It is, again, not painful surgery. There are no dietary restrictions because there's no wound in the mouth or in the pharynx. We don't put a drain in the wound, not necessary, and we want to avoid that because of infection risk. And then the first 4 weeks, we do nothing. We let the wound heal. Then after a month, the patient comes back, and then she will be instructed how to use her remote control. And in this remote control, there's a start delay. So when you put it on, it will not start working directly. So you have time to fall asleep. There are power settings in which you can increase and decrease the power. patients get about another 4 weeks to get adjusted to it and to gradually increase the power settings until after about, let's say, 8 steps, it starts getting uncomfortable. Then you go 1 step down, and now in 80% of cases, just after 1 repeat sleep study, the effect is good. Things are getting easier. While in the beginning we had 3 incisions, we now have 2 incisions. Easier for the surgeon. It leads to less long operating time. And in theory, complications that might happen because you have 1 more tunneling procedure and 1 more wound to open and close. Probably, or it is likely that infection rate, which is already low, can be getting much lower again. So while in the beginning the 3rd incision was here, we now place the sensor under the IPG. In the beginning, the idea was that it might lead to a suboptimal sensor signal, but we now know that the sensor signal is in fact even better. Again, the pivotal trial was the so-called STAR trial, in which we looked into safety and effectiveness of upper airway stimulation in patients with moderate to severe sleep apnea. And in responders, after 1 year, we stopped the therapy for 1 week, repeated the sleep study to compare what the effect was with on and off mode. Inclusion at that time was an AHI, the number of events per hour of sleep between 20 and 50. Patients should not, would have to be failures or not tolerate the standard treatment CPAP. Percentage of central mixed apnea should be less than 25%. Patients should not be positional because there are other solutions for it, and they should not have what is called complete concentric palatal collapse during drug-induced sleep endoscopy. And at that time, BMI was supposed to be below 32, because we know that in higher BMIs, the success rates of sleep surgery and upper stimulation are less good. At that time, the reduction of the AHI that was after 1 year was 68%. And also 70% in the oxygen desaturation rate. So there in sleep apnea, there is often a discussion what is the best metric, this AHI or the ODI, but here doesn't it matter, they're completely the same. A clinically relevant improvement in quality of life and a clinically relevant reduction in the Epworth sleepiness scale, so both objective as subjective results are good. That was after 12 months. We repeated the sleep studies after 18, 24, 36, 48, and 60 months. And we're now looking at 10 years results, but so far these results have remained stable. They don't deteriorate in the course of time. Presently, there's a lot of literature about upper airway stimulation. There are more than 150 papers already on this topic. More than 2,000 patients have been reported. There have been publications about patient selection, implant procedures, care pathways. There have been comparative studies, and upper airway stimulation is now in several international OSA treatment guidelines. 2 important studies that I would like to end with. There is the so-called ADHERE registry, which is a large-scale international registry in which patients with all kinds of aspects of follow-up are entered. Maria Surna from New York published last year in Laryngoscope an interesting study in which we compared in that ADHERE registry patients with a BMI below 32 and between 32 and 35. And important, and let's have a look here at the AHI, is that these AHI in both groups were comparable, but that the effect of upper airway stim in both groups of patients is completely the same, which actually means that this BMI cutoff point is not important. At that time we thought that it was, but as long as a patient doesn't have this complete concentric collapse during drug-induced sleep endoscopy, then the AHI is less important. So even more obese patients who cannot lose weight for one reason or another do as well. The second study that was just published last week online in Journal of Clinical Sleep Medicine is, in my perspective, the most important study yet after the STAR trial. In this, again, large group of patients, almost 2,000 patients, again from the ADHERE registry, we have looked in 5 different subgroups depending on disease severity. So there is this group with an AHI below 15. I'm not sure why this patient had this surgery, but there must have been a reason for it to do it already in mild OSA. Here's a group with patients with moderately severe sleep apnea. Then the group between 30 and 50 events per hour. Then a group with an AHI between 50 and 65, and even patients with an AHI of 65. So 5 different groups. The overall reduction of the AHI for all patients is from 33 to 7 after 6 months, and finally to 10 after 1 year. Comparable reduction in the ODI, the same improvement in the upper sleepiness scale from 11 to 7 and 6 with the ESS. So convincing outcomes for the total group. But important is that when you look into the different disease severity groups, that even in those patients with extreme sleep apnea, with an AHI above 65, they have a fantastic, very comparable reduction as the less severe cases. So the clinically relevance of this is so, as I see it, so important, because as a doctor, I see every week patients who have a CPAP failure are referred for upper airway stimulation, and then their AHI just a little bit 50, and we cannot do it because there are excluded from this kind of treatment. So those patients with even a higher disease burden are denied so far this kind of treatment. In the Netherlands with an AHI above 50 and above 65 in other countries. But I believe that this is a strong argument to offer this treatment to the more severe patients as well. Important is also the compliance therapy usage, hours per night, and you see that in all 5 disease categories, patients use their upper airway stimulation almost all time, which is understandable, and this compliance is in fact higher than many patients who use CPAP or oral devices. Then when you ask patients, are you happy with it? So the clinical global impression scale, you will see here for all disease severity groups that most patients are very happy, much improved, minimally improved, no change, but the most patients are in this very happy with it group. Then with the questionnaires, do you think it is better than CPAP? All patients, 90%, oh yes. In the highest severity group, 92%. Would you choose it again? Yes. Would you recommend it to friends and family? Yes. Are you satisfied with it? All pretty convincing. Therapy response, again, per different groups in every way that you can look at it. The so-called SURE criteria in the AHI below 20, the reduction of 50% in all groups, and very good outcome. So future perspectives of this Inspire therapy, in sum, we do hope to get permission to do this kind of implants also in patients with high disease severities. We hope that this BMAP 32 is not longer a cutoff point as long as patients have a favorable finding during DICE. Higher BMIs should also be acceptable. You have to be aware of patients with mixed sleep disturbances. So patients with insomnia can react less good because when the system is on and they have difficulty with sleeping, it might be even more difficult to fall asleep again. Not too much mixed and central apneas, because you don't know what the effect of further opening of the airway will be, and then how far this mixed or central component would disappear or not change or get worse. So presently we don't do that yet. Positional patients should be offered positional therapy first, but those patients who don't react to it can still be good candidates for upper airway stimulation. And another thing is combined therapy. Most patients are good with only upper airway stimulation, but there are people who have a nice opening of the obstruction at tongue-base level, but they have residual palatal collapse. And in such cases, additional sleep surgery at the level of the palate could be a consideration. I think this is it. Thank you very much for your attention.